and all the PG students. We are very happy to welcome you once again for our 12th topic. Today's case discussion is on decompensated CLD with upper GI bleed. Very happy to welcome our examiner, Dr. Prithviraj Saha. He's an associate consultant from Fortis Escorts Heart Institute, Okhla, New Delhi. So thank you very much, sir, for joining us today for the meeting. And I'm sure today's learning is going to be enriching for most of the students. We are expecting more to join, but yes, we can get the meeting started. I also take this opportunity to welcome Dr. Kurian Babu, who is also a student in Apollo Adelaide. So thank you, Dr. Kurian, for accepting to be taking this case. So I wish you very best of luck for today's program. So thank you very much. Over to you, Dr. Pratyush.
Thank you, sir. Thank you, first of all, organizing this type of program. It's a rare program in nowadays, while DM, DRNB are in already in floor for last 3-4 years, and many DRNB students are coming out, and I am one of them, luckily, who have passed an year and a half ago, 1.5 years ago. So it's a privilege to interact with the new residents, and thanks again for giving this type of platform. So what we will be doing today, is my screen visible?
Yes, sir.
Okay. It's full screen, na? So, so what we will be, 1 second, just. Yeah. Yeah. So we will be having a quick revision of a long case Viva, and it's a mock preparation for his Dr. Kurian upcoming exam, which is shortly happening within this June, July theory, and after that practical. So one thing, Dr. Kurian, it's very important that we both are here not as an examiner and an examinee. These are the term which needs to be given in the flyer. But as a senior and junior, we will be discussing some aspects that you need to focus during your exams, right? You are not sitting in Kochi or in southern part of India. I am in northern part of India, and this DRNB course and this DNB course has a rule that we have to fly from here and there to appear in different parts of the India. So in your exam, the case will be a double blinded case, right? What I mean by double blinded, that you will be seeing the case for the first time, so as your examiner, right? Until and unless is the internal examiner, the external examiner will also see the case for the first time. So you have to remember, whatever direction you will take me, I will go in that direction only, right? So today I am not blinded. I have prepared the case. So, but in either way, during the exam, the topic given is the decompensated CLD with an upper GI bleed. I can make you sure that 99% of the time you will be away from the case, right? So DCLD will not be discussion. We will be discussing something regarding the ventilator, thromboprophylaxis. We will be discussing regarding the infection control practice, right? So we have to keep in mind everything which is in topic and which is out of the topic. And that what my experience is, that the senior teachers, when takes exam, they try to go away from the main topic because they all know that you have read the main topic thoroughly, right? So we will be in topic for some time, out topic for some time. So I have choose 14-15 domains over this topic. So we'll be discussing, as I have done in the previous 2-3 case presentation of the last exam going batch. So this is start with the case, right? So will you read or I will read? So
Sir,
you
I'll
can
read,
read.
sir.
Okay,
Yes, sir.
you read. Okay.
So, a 60-year-old chronic alcoholic male came to the emergency department with a history of two bouts of massive hematemesis in last 2 hours. He was complaining of decreased appetite, generalized weakness of for last 1 month, and pain abdomen for the
Sorry.
pain abdomen for the last 7 days. He has a history of type 2 diabetes, hypertension, post PTCA done in Jan 2025 with a ejection fraction of 45% and a history of atrial fibrillation. He has no history of chronic liver disease. He had a history of peptic ulcer disease for which he was treated 4 years back in a local hospital for severe abdomen pain.
Exactly. So this is the brief history which you exactly get at the bedside when you arrive at the exam center, right? So from this history, can you please say me what are can be the possible cause of this massive hematemesis? What are the possible causes? What you get from this history? Top three or top four?
Sir, one is a Mallory-based stare because of the vomiting. Uh,
Excellent. Also
then
alcoholic.
alcoholic.
Yeah,
Then a peptic ulcer disease,
very good.
bleeding from a gastric ulcer, and
Excellent.
then possible is varicose hemorrhage.
Very good. And something more for which I have prepared the history little in details.
Then since he's already on antiplatelets and anticoagulation, probably for the atrial
Excellent,
fibrillation and the
excellent.
post PTCA, so he can bleed
And
torrentially.
one last. He had
Um,
an yes, please. So he had a history of atrial fibrillation, and which
yeah.
almost most of the time this patient on atrial fibrillation has a history of NOACs or a DOACs. So it can be a NOACs and DOACs induced bleed. Though NOACs and DOACs has a low incidence of GI bleed, but it can be also DOACs and NOACs related bleed, right? Very good.
Yes.
Excellent. You have started not, you are not biased with the chronic liver disease. You have gone one by one, and that is where you should do in the exam. The most catchy, you keep it in 2 and 3, and some surrounding you keep it on top or second, because you often get biased with the chronic liver disease, alcohol history. So peptic ulcer, thrombotic, antiplatelet related bleed, and the peptic ulcer, and also the chronic liver disease. Now coming to this chronic medication. So in seeing these chronic medications, the patient is on Amlong and Telma for hypertension, glimepiride, metformin, epagliflozin, a DAPA 10 mg OD, metoprolol 25 mg BD, ecospirin 75 mg OD, and atorva 40 mg OD. I have left a small space in between this drug. Do you think any drug history am I missing which should be taken from this patient?
So since he is having history of atrial fibrillation, we have to ask for history of any anticoagulants.
Excellent. So the patient is on tab Eliquis 2.5 mg BD. Can you say what is this Eliquis drug is?
I think it's apixaban.
Mechanism of action?
It's a factor 10A inhibitor.
Excellent, excellent. Do you know if the patient on an Eliquis or an apixaban bleeds, what is the reversal agent of choice?
So it is andexanate alpha.
Is it available in India?
Uh, no, sir.
What is the second line of choice?
Sir, it is a four-factor PCC.
Very good. What are the four factors?
Factor 2, 7, 9, and 10.
Excellent. What is three-factor PCC? Which one is missing?
So factor 7 is missing in three-factor PCC.
Can you
Only
say can you say what is the dose of this four-factor PCC in a DOACs induced bleed? I'm just getting off track. The thing is, this will be your situation in your exam, right? As you
Yes, sir.
go, your viva will go in that way. So, can you
Okay.
say what is the dose of this 4-factor PCC in a DOAX induced bleed?
So 50, 50,
Does it depends
not,
on INR? Does it depends on INR?
um, not sure.
See, it's 25 to 50 unit
Uh,
per kg in
okay.
case of warfarin, depending on INR. But
Okay.
unfortunately, the DOAX and NOAX doesn't affect the INR. For DOAX and NOAX bleed, it's 2000 unit bolus, right? So
Okay.
it is 2000 unit bolus. It means 4 vials, 3 to 4 vials. Each vials contain 500 unit, right?
Units.
So
Okay.
3 to 4 vials for a DOAX or a NOAX induced
No.
bleed. Adnexanet alpha is not available, so it's
Mm,
very good.
okay.
So now coming to the examination, you can read.
The GCS of the patient is E2 V2 M4. He is drowsy but arousable. The pulse rate is around 124 per minute. The blood pressure is 82 bar 58. The skin peripheries are cold. The chest bilateral vesicular breath sounds are heard. The cardiovascular system examination is normal. Pallor is present. Jaundice, clubbing, and all is absent. Pedal edema is present.
Excellent. So from this history, now what's your
Mm.
diagnosis? From this examination, after this examination,
Mm.
what's your diagnosis regarding the condition of the patient? Is the patient in shock?
Yes, sir. He's in shock.
What do you mean by shock?
Sir, here the systolic blood pressure is less than 90.
No, I am asking how do you define shock?
The map of less than 65, SBP of less than 90,
No,
also with the
no,
microcirculatory.
shock definition. Please don't tell MAP and SBP, right? Shock is a systemic manifestation of tissue hypoperfusion, right? Which is unable to meet the metabolism of the tissue manifested by three windows, right? This should be your tip in the tip of the tongue. It's a systemic manifestation of tissue hypoperfusion, which is unable to meet the metabolism of the tissue manifested by three windows: altered sensorium, cold and clammy skin, decrease urine output, right? This is the
Okay.
classical definition of shock. Avoid telling any BP in the definition of shock, right? Because there are what is called normotensive shock, right? So
Yes, sir.
when we say normotensive shock, the BP doesn't fall, right? So
Mm.
here you have a fall of BP, but the patient can be in shock without the fall of BP, right? So you are right. Here the patient has an hypotension and a tachycardia. Looking into this and the clinical scenario, what type of shock do you expect in this patient?
Hemorrhagic shock.
Excellent. According to the classification of hemorrhagic shock, what class does it fit? At least, I am not saying,
Um,
because I am not said told you base excess anything, right?
yes, sir.
So, uh, so there is an in
Class
uh,
3.
right. Say
Class 3.
class
Mm.
3 is, yes, you can go because the SBP has dropped correctly. It's class 3 or class 4, and there is a decrease in the pulse pressure. So it is minimum class 2, and as the SBP has dropped, it is class 3. Absolutely right. Right. And
Okay.
so there is a drop in BP, cold and clammy skin. So what are the microcirculation parameters you look into for a shock?
Sir, we can look into the capillary refill time, uh,
Excellent.
la lactate levels.
Excellent.
Then we can look into the PCO2 gap.
Excellent. Excellent. Excellent.
Uh,
What
then
will be the
the
PCO2 gap here?
it
Expected?
will it should be more than 6.
Excellent, excellent, excellent. You have read excellent according to your because these are very conceptual thing. So we hope to have a much more good discussion in the next slides. So excellent. Yeah, it is PCO2 gap greater than 6 for shock, and then we will be differentiating by giving fluid whether it's improving or not. Then we will be differentiating it's cardiogenic, septic, or hypovolumic, right? So SCVO2 also you can say, you can
Yes,
also
sir.
see for SCVO2, right?
Mm.
So these are the from the examination. So any further examination do you need to do in this patient for excluding your differential diagnosis?
Sir, focus.
Focus, all right, it's a luxury. Ah.
Okay. Um,
Not, I will say not
ABG,
luxury, but at this moment it's a luxury. Ah.
ABG,
Right now I am saying physical examination.
physically okay.
You are on the absolutely right track. Just think logically. Patient alcoholic with bleed.
We have to see for the features of
Exactly, exactly.
CLD.
Very good. You have to look into the abdomen. You have to look into the features for CLD. So in abdomen, it's distended with everted umbilicus, dull on percussion. There is a splenomegaly. What is the method used in this massive ascites to check for splenomegaly? Just name.
Uh, two hand, two hand method. Both the hands
Dipping method.
dipping method. Yeah.
Dipping method, right? Exactly. And the patient is drowsy but arousable. So you need to see for whether the patient is bleeding outside and also whether the patient is bleeding inside or not, right? So if the
Yes, sir.
patient is having any intracranial bleed, so you have to look for the pupil. And I have missed one thing. I am not saying ki in these patients you will continue looking for these examinations. We will come to the management part, but I am just completing sequentially that anything need to be seen apart from pupil, neurological.
GCS.
TCS is E2V2M4.
Yeah. Okay.
Say, you will be able to answer. I am pretty sure. Plantar, right? So
Plantar
if I
side.
have the scope to, you can see the plantar, whether there is a bleed, whether there is any extensor on any side, right?
Okay. Okay.
So we will be suspecting any, because the patient is drowsy. You don't know whether the patient is drowsy due to hypotension, whether the patient is drowsy due to the alcohol intake which he has taken few minutes or few hours before. So it's very difficult. So this can exclude at your bedside whether you will think for an CT or an neurological imaging in subsequent time, right? So now please tell me, at this moment you have gone to the ER, the patient is at the bedside. So what will be your line of management now?
Sir, my line of management is first thing is I'll go by airway breathing circulation.
Excellent,
So
excellent. Anywhere you start with airway breathing circulation. Then, so will you
so the
intubate this patient?
um yes, sir, I'll intubate this patient.
Like, no, if and buts. GCS
Mm.
is poor, right? Drowsy but arousable. Patient has bleed, and I will show you the ABG now, right? So after seeing this ABG, can you say me the diagnosis of this ABG?
There is a
Just take 1 minute time. Just see.
um, it's a high and metabolic acidosis with high anion gap, metabolic acidosis.
What is the anion gap here?
Sir, it is around 20. So 25, around 25. Like 140 minus 98 plus by car, 15.
9815 is 113, right? And your sodium is 140. So it's
140.
27, I think. No?
Yeah, 27. Yeah,
27. So is your answer final?
With
No,
partial.
just anion gap. Is your answer final? Or do you want something from me? Relax, just relax. You are doing absolutely great. That was I am asking you. When you are getting this type of questions, means you are almost beyond passing limit, right?
Okay.
Anything more you need for anion gap? Albumin correction, right?
Albumin.
So you should have asked me, sir, पहले तो आप albumin बताओ, फिर मैं आपको answer देने वाला हूँ. So your approach should be this in the final exam, right? So you are passing the topmost degree of Indian medical education, right? So there is no if and buts regarding that, right? It's the topmost degree of Indian medical education. So your approach will be कि sir आप तो sir पहले please give me the albumin level before I say you the anion gap, right? Can you say me the correction? If the albumin level is 2, any idea regarding the correction?
Correction.
It's 2.5. No, take
2.5.
it's 2.5. For per albumin drop, it's 2.5. No issues.
2.5.
So can you say me the full diagnosis now?
So it's upper. A patient is having high anionic metabolic acidosis, presenting with an upper GI.
No, diagnosis from this. I mean to say the diagnosis of this ABG.
Okay, so this is a high anionic gap metabolic acidosis with partial decompensation.
Partial decompensation means? See, there is no word such called partial decompensation. Okay, I can take you with, can say you with guarantee. There is no word called partial decompensation.
Partial respiratory
No, there is nothing. So there is an additional respiratory acidosis in this patient, right?
Yes, sir.
So that means the patient is in an impending respiratory failure, right?
Okay.
So this give you an clue. Just a minute, it's disturbing. This give you a clue that the patient is going to be an impending respiratory failure, right? So we need to intubate the patient, right? So the PCO2 is 35, which is pretty high in comparison to this bicarb level, right? The bicarb is 15, it's 9. So it should be around 1.2, 10, 11. It's a 29 to 30, right? PCO2. So, but the PCO2 level is pretty high. So we should be thinking of intubating this patient without any thought. So if I intubate this patient, what exactly the term of the airway we use for this patient?
So physiologically difficult airway.
Excellent. Can you define physiologically difficult airway for me? So this is the thing now, what I am trying to, why I am going in these directions. You may go and say कि यार sir बोला तो था DCLD discuss होगा, because this is how the exam happens, right? Any word you utter, the question becomes the second, right? So when you are uttering, then you should be prepared for this question, right? So it is the pathological or the physiological condition of the patient which makes it difficult to intubate or secure the airway, until it's transition to the positive airway pressure, right? So until you not only for airway putting the airway inside, until you transition the patient to the positive airway pressure, there is a fall in the BP. Till then, the airway, if it is threatened due to the physiological or the pathophysiological, physiological means it's maybe due to pregnancy, due to something else, or the pathophysiological condition, if it is hampering the airway, not anatomical, then it is physiological difficult airway. There is an excellent article and a guideline which came in 2024. Sheila Maitra ma'am was one of the part of that. Please go through that article through and through, because it's a very famous question of DRNB theory, right? So what is the induction agent according to that guideline in the physiologically difficult airway? So show the guideline. If you intubate this patient, what induction agent will you use?
I'll use ketamine
Or the
or
patient
etomidate.
already drowsy. Excellent.
Etomidate.
So the patient is already drowsy, arousable. Ketamine you can use. So the two options are there. So do you know a recent trial has come between this ketamine and etomidate? Just a
Yeah.
month back.
Yeah.
So go back and
Yeah.
read that trial, right?
Mm.
So go back and read physiologically difficult airway, etomidate or ketamine. Number two, whether to use fluid boluses or vasopressors during the intubation. All trials are there, right? So be prepared with the trials. As you are answering very well, you can expect these questions in your exam also, right? So let's go forward. Now, patient intubated, ventilated, put on VCV ventilator, FiO to 50%, tidal volume 420, PEEP 6, respiratory rate 20 per minute, right? So the patient is on put on ventilator, patient put on CVC catheter in view of high vasopressors, multiple drug infusions, and arterial light in situ. So three basic questions as you will be standing at the bedside during your exam. Your examiner will ask you if the patient is on VCV ventilator, what is the T, L, and C of VCV mode? Means trigger, limit, and cycle of VCV mode.
Flow trick.
No. See, VCV means control.
Volume,
it's a control mode, right?
Yeah.
So everything is controlled by machine only. So the trigger will be time trigger.
Time trigger, okay.
After a certain time, the breath will be given, right? So what will be the limit? What you are telling now, that is limit, flow.
Oh, flow limit.
Right? And cycling is, some say time cycle, some say volume cycle, right?
Volume cycle, okay.
So the thing what I am trying to make you understand and what's the reason of agreeing to this session is not to teach you CLD. For that, you have a department, you have books, and you are an excellent meritorious student, so you will read that. So the thing is, while you are standing at the bedside in the DRNB third year final exam, your eye should go everywhere, right? In my final exam, I will share you and one experience. One PRVC mode was going on, and the examiner tried to make me convince that it's a VCV mode. Right? Madam tried to make me convince it's a VCV mode, but I will not say I fought at the bedside, but I literally argued that I do not agree. Because what makes you difference from the PRVC to VCV? Any idea? It's the pressure graph, right? In the PRVC, it's a pressure controlled breath. In volume control, it's not a pressure control breath, right? There will be P flat, P peak, right? The typical pressure wala graph will be there. So one last question from these box. For putting a central line, what disinfection you use?
AHD.
Hmm?
Sir, for
Chlorhexidine,
putting a, yeah,
central line.
chlorhexidine. Yeah.
Chlorhexidine. What is the concentration of that chlorhexidine which you use daily in putting a central line? Weight by volume. And what is the concentration? What, because everything will be at your bedside, right? A hand rub
Yes,
will
sir.
be there. So an examiner will go to that hand rub. Huh?
Okay,
First of
okay.
all, remember touching the patient using that hand rub again and again. ठीक है,
Yes, sir. Okay, sir.
वेंटिलेटर टच करना कुछ भी करना भाई वो तो दिल पे ले लेता है एग्जामिनर। ठीक है, अगर
Yes,
तुम
sir.
हैंड रब नहीं यूज करे हो, ऐसे कि तुमने
Yeah.
मार ही दिया पेशेंट को, ऐसे करते हैं। ठीक है, सो ऑलवेज यूज हैंड रब। सो व्हाट इज द कंसंट्रेशन ऑफ दैट हैंड रब एंड व्हाट इज द कंसंट्रेशन ऑफ द टिंचर you use in the CVC? Any idea? If not, we can go forward.
Um, I 2%.
Exactly 2% while putting CVC,
CVC.
0.5% in hand rub. It's weight by
Okay.
volume, right?
Okay.
It's
Okay,
not
sir.
volume by volume, it's weight by volume in 80% alcohol, both in 80% alcohol, right?
Okay, sir.
Okay. Okay. So now, come, patient intubated. हाँ, एक तो
Mhm.
तुमने पड़ाव पार कर दिया, पेशेंट इंटूबेटेड, एबीसी, एंड दिस इज द मोस्ट इंपॉर्टेंट थिंग। जितने जो बोल दिया हीरोइज्म, पहले तो पेशेंट का लाइफ सेव करना है। सो वी सेव द लाइफ, पेशेंट इंटूबेटेड, पुट ऑन वीसीवी मोड, राइट? आर्ट लाइन,
Hmm.
सेंट्रल लाइन सिक्योर्ड, वी हैव डन द बेसिक फर्स्ट ईयर सेकेंड ईयर वाला काम। नाउ एज यू इन द
Hmm.
थर्ड ईयर, नाउ सेकेंड ईयर आके पूछेगा तुम्हें कि सर इसका ड्रग चार्ट में क्या भरना है। So just
Hmm.
tell me what will be your pharmacotherapeutic plan till now, because you are
Hmm.
not sure that this is an varicose bleed because the endoscopy has not been done till yet, right? So
Yes,
what
sir.
will be your drug chart?
So I will start him on pantoprazole infusion.
Excellent. What is
80
the
mg,
dose? Can you, huh?
8,
Yeah.
80 mg start and 8 mg per hour. We can start on, and then we have to, because he's in shock, we have to start noradrenaline
Yeah.
for the shock.
Not, it's already noradrenaline.
Okay. Yeah, then we can, since it's a GI bleed, we can start on a antibiotic, ceftriaxone 1 gram can be given.
Okay.
Uh,
Anything more?
then
Say. You use every day.
um,
Any vasoactive agent?
we can use terlipressin or octreotide.
So now go back by seeing this history.
We have to stop all this.
No,
Um,
this history. The name, two name you uttered.
yeah, post PTCA.
So what will be your
Hypo.
drug now?
Mm, so noradrenaline, but will be, yeah, will have an effect.
Exactly. That's what I am
Yeah.
want to hear. That noradrenaline will suffice your action of vasoconstriction, or what exactly you want to constrict? It's peripheral vasoconstriction or something else?
Splanchnic.
Exactly. You want to constrict splanchnic vasoconstrictor. So do you have any idea what extent this norepi is required to constrict the splanchnic circulation? It's an excellent peripheral vasoconstrictor, right? So
Mm.
for constricting the splanchnic circulation, the norepi required is in the very high dose. So if you are getting a norepi of 15, 20, you are adding on vaso, so maybe you do not require adding another vasoactive agent, because see, terlipressin, if you could have used, you could have used, but this patient is in post PTCA. if you also want to use, you should be using with very cautious, because it's a potent coronary vasoconstrictor, right? So apart
Okay.
from the splanchnic vasoconstrictor, using, so the question is, what I would have asked you, say anything you need to test before using a terlipressin is one, history of coronary circulation insufficiency, or any history of mesenteric ischemia, and an ECG with any ST changes which is corresponding with the acute coronary syndrome or the acute coronary event, right? So you should be very careful, as this patient is having a post PTCI, and that also a recent post PTCI in 2025. So I prefer avoiding terlipressin here. So other options are octreotide and
Noradrenal. Almost.
uh, say
Somatostatin.
exactly. Can you say the dose of octreotide and somatostatin?
So octreotide is given as 50 microgram stat and 50 microgram per hour infusion.
Excellent.
Somatostatin, I forgot, sir.
250,
250.
right? 250 stat and 250 as infusion. So
250.
chalo, post PTCA bhul jao. What is the dose of terlipressin here?
So terlipressin, we can give 2 mg 6th hourly for first 2 days and then 1 mg 6th hourly for the next 3 to 5 days.
What is the receptor responsible for the action of terlipressin?
Um, V2, I mean,
No, V2 is in the
uh,
kidney. It's the
yeah,
site of action of
V,
ADH, right? Ki
yeah,
vasopressin.
no.
It's V1A, right?
V1,
In
V1,
smooth
okay,
muscle. Can you
okay.
say where is located is the V1B?
Um,
It's in the
not sure.
pituitary. So everything when you read, now you read in this sequence, right?
Okay.
It's not obviously today the game is not double blinded. I have prepared the slide, right? In the
Mm,
exam, it will be a double blinded. More question will be from this chlorhexidine, volume graphs. Because वो
okay.
examiner उस दिन आया फ्लाइट पकड़ के दिल्ली से, राइट?
No,
तो उसको भी पता नहीं है, पहले तो सर लोग सब एक साथ मिले, बात किया. सो ठीक है, दे विल बी मोर कंसर्न इन जजिंग यू. एंड मोस्ट मेनी एग्जाम्स हैपन आउटसाइड फ्रॉम द बेड ऑल्सो, राइट? बेड के पास भी नहीं होता है. So they will be
okay.
more concerned in judging you ki whether you are totally complete to launch in the market, right?
Okay,
Nothing
sir.
more than that. Okay.
Mm,
So the thing everywhere in MD anesthesia also, my HOD told me ki the motto of the exam is whether you are safe to be launched in the market. Nothing more than that, right?
yes.
No heroic trials or any heroic discussions, right? So so now when the word of trial came, is there any role of tranexamic acid here?
No, sir. There is a halted trial which showed that tranexamic
Excellent,
acid is not used.
excellent, excellent. Excellent. But if I am talking regarding a CLD patient, do you think there is any role of tranexamic acid in a bleeding CLD patient? If it is not a
Um,
variceal bleed. In variceal bleed, there is no role.
okay.
But there is a condition in the CLD where there is a role of the tranexamic acid. There is a
Uh,
condition in the CLD patients which is called acute intravascular coagulation, accelerated intravascular coagulation and fibrinolysis, right? In
okay.
CLD, a patient bleeds for four reasons,
Mm,
right? One is portal hypertension. Second is the mucosal bleed is the platelets, normally due to the platelets or the fragile mucosas, right? One,
mm,
rarely a patient bleed due to the coagulation factors, very rarely, right?
okay.
Very, very rarely I have seen a patient bleeding due to the altered coagulation, right? We will be coming that at the last of this presentation.
Mm,
And another is this accelerated intravascular coagulation and fibrinolysis. There you get a deranged in the LY30 in the tag, right? There is
Okay.
an
Okay.
accelerated LY30 and the patient bleeds due to the fibrinolysis. The fibrinogen level comes down, but the difference from the DIC is it only affects the LY30, right? Mainly
Okay.
it
Okay.
affects the LY30 because the problem is with the fibrinolysis. And in that patient, in those cases where nothing is working, you can have a try with tranexamic acid in a bleeding CLD patients, right?
Okay.
So, pharmacotherapy, you have excellently said here, where as the patient is on high vasopressors, we don't need anything. If at all we will be adding octreotide or somatostatin. As the patient is post PTCA, you have started on a pantoprazole infusion and an antibiotic you said is injection ceftriaxone. Why you want to add an antibiotic in a bleeding patient?
Sir, sir, there is a break in the epithelium, mucosal epithelium, and there is translocation of bacteria can happen. So we need an antibiotic cover.
So you think due to the bleeding, so in any bleeding patient, do you add an antibiotic?
Um,
If a varus is bleeding, do you see from the behind that varus some bacteria will come out? So what you are saying, you are
gut,
on the
gut,
right
gut,
track.
gut bacteria translocation.
Exactly. So what happens in a CLD patient, then in a portal hyper. So what do you mean by spontaneous bacterial peritonitis?
So
Why
when
it happens?
it happens because of weakened immune system and translocation of bacteria through the gut
Exactly. So there is
wall.
no breach. So there is no breach in the
Mucosal
epithelium. So if I
epithelium.
would mean, so what type of peritonitis it is? Primary, secondary, or tertiary?
Primary.
Exactly. So if there would have been a breach in the epithelium, it would have been a secondary peritonitis, right? So there is no
Yeah.
breach in the peritoneum. So what exactly happens? Now the story is egg before or chicken before, right? Like that
Mm.
only. So what happens in a patient who is bleeding due to the variceal bleeding, that may be due to an SBP, an infection in the ascites, which has aggravated the portal hypertension and lead to the bleeding, right?
Yes, sir. Right.
Or a bleeding which is happening due to the increased portal hypertension due to any other precipitating factors will cause translocation of bacteria and will cause SBP, right? So
Okay.
either way, it can happen. Increased portal pressure can cause SBP, or an SBP has triggered this bleed, right? If I am
Okay.
thinking of variceal bleed. So to cover basically the SBP, it's ceftriaxone because it's a third generation of cephalosporin which is covering the Enterobacteriaceae, right?
Okay.
So what is the most common organism associated with spontaneous bacterial peritonitis?
Uh,
I have only said the answer. You just recall, and this is
um,
ceftriaxone. So
yeah.
it's a gram negative because
Gram
ceftriaxone is
negative
a third
gene.
generation. Second
Yeah. Yeah.
generation onwards, gram positive weakens, right?
Yes, sir. Yeah.
Cephalosporin. So it's a third generation. So the third generation will be covering a gram negative, and in the
Mm.
gut, the most common is the
Klebsiella.
नॉट क्लेप्शियला. अभी तो चलो आ गया हमारी, हमने इंडिया पे
E.
बना
coli.
लिया क्लेप्शियला को. इट्स इकोलाई, राइट?
E. coli.
It's the so the Enterobacteriaceae, the most common organism is Escherichia coli, right? Perfectly.
Okay.
Now coming to this, so now your focus. So you can read.
Mm. So the IVC is around 1.4 centimeter with more than 50% collapsibility. The left ventricular ejection fraction around 40%. Global hypokinesia with a heart rate of 120. Baseline ejection fraction is around 45%. The lung is showing A profile lung. and there is a right base pleural effusion with stretch sign and dynamic air bronchogram.
Okay, just to
Uh,
interrupt you here,
mm,
what your vision from this focus? अब तो चलो गैस्ट्रो को बुला लिया, गैस्ट्रो इज कमिंग ऑन द वे, रात 3 बजे गैस्ट्रो की एसोसिएट कंसल्टेंट ही आएगा, कंसल्टेंट तो रात में आएगा नहीं, वो भी आ रहा है, रास्ते पे है, ठीक है,
mm,
तुम भी हो ड्यूटी पे, सीनियर ड्यूटी विद सेकेंड ईयर फर्स्ट ईयर, राइट? सो
yeah,
you have seen a focus. So what this
yeah.
focus is giving you an idea?
Sure, there is a right lung consolidation because of
Very good.
the stretch
How?
sign and dynamic air bronchogram.
So where
Yeah.
you see static air bronchogram?
Sir, atelectasis.
Exactly. Very good. And right base pleural effusion, which red shine, dynamic air bronchogram. But the lung is having an A profile. What I mean by this A profile?
A profile means the lung is dry.
And having a
It's a reverberation artifact of the pleural line. A profile.
exactly, very good, very good. It's an A line, right?
A lung. Yeah.
So this A line, B line, what's that protocol is called?
Blue protocol.
Very good, excellent, right? So coming to the LV, ejection fraction.
Uh, there is because of the tachycardia, we cannot really comment on the
Excellent.
ejection fraction.
एंड चलो टैकिकार्डिया सही होने के बाद भी अगर ये सिनेरियो है,
There's a heart failure with reduced ejection fraction. So cardiogenic plus
हार्ट
there is a
हार्ट नहीं नहीं नहीं, एक सेकेंड, हार्ट फेलियर कहा, लंग तो ड्राई है.
stunning of the heart.
Exactly.
Yeah.
So what type of MI or ACS are you suspecting in this patient? 1, 2, 3, 4.
Type
Say, you will
type
say
4.
right. Not type 4, it's
Type
type 2.
1. Type 2. Type 2.
It's mismatch between the supply
Yeah.
and the requirement, right? So as the patient does bleed, so there is a global, there is not a regional wall abnormality. So there's a global hypokinesia and the EF. So we expect this EF will improve once we resuscitate the patients and the patient comes to the baseline hemodynamic, right? So
Yeah.
now we are coming from below, IVC 1.4 greater than 50% collapsing. What do you mean?
That means patient is requiring fluids more than 50%.
So now my question is, do you need an IVC in this patient to say that this patient is fluid responsive or not?
We can check the fluid responsiveness
Do
through
you
other measures.
need, my question is, do you need to check fluid responsiveness in this patient जितना सिनेरियो अभी तक हमें मिला है?
Yes, we have to check because patient is in shock and requiring support. So
So
we can see if we can give the fluids.
So my question is, when a patient comes to the ER with a septic shock, with a pneumonia, fever, and a hypotension, do you check fluid responsiveness to give
No,
fluid?
initially we have to resuscitate with fluids,
Exactly.
and
So
then
we are now in a resuscitation phase, right? So what is
okay.
the indication of fluid responsiveness in the textbook written?
The indication.
Indication
To
is
see,
when the patient is in shock, hypotension, but there is no obvious cause of hypovolemia, right? So when there is an obvious cause of hypovolemia, you don't need to check for fluid responsiveness. You will go for resuscitation, right? This is number one. Number two, when we are talking regarding fluid responsiveness, what is the definition of fluid responsiveness?
we can check fluid responsiveness by different means.
A
Like
definition.
definition means it should be in the seat portion of the
No, definition.
uh,
Exact definition. Is the increase in the cardiac output or stroke
cardiac output
volume by 10 to 15% by
10%.
giving a
Bolus of around 500 ml. Fluid,
not
meaning fluid boluses.
no. Don't confuse everything. So
Uh,
you are still you have a 6-8 months time. You have to read this. Definition of fluid responsiveness is the increase in the cardiac output or stroke volume or VTI, as you say, by 10 to 15% by giving a bolus administration of crystalloid of 4 ml per kg, right? So 4 ml per kg exactly it is written. Now mini fluid if you comes, it becomes colloid, it's become 100 ml and the increase in the cardiac output becomes 6%, right? So these are all different areas. We should not be confusing, but fluid responsiveness, the my motto of putting it here is इसी टाइम में तुम्हें आईवीसी देखने का जरूरत नहीं है. We are
okay.
dealing with an 4.8 hemoglobin patient. We are dealing with a patient who is hypotensive on a high vasopressors. अभी तक bleeding का source control नहीं हुआ है. So,
Okay.
and the ejection fraction is very good. Working in a cardiac
Okay.
hospital, to us 45 is a very high figure. ठीक है. सो
Okay.
30-35 के ऊपर तो मिलता ही नहीं है हमेशा. सो 45% EF baseline, you give fluid and fill the patient till you use the blood products, right? Till
Yeah.
the bleeding source is controlled, right? So
Yes.
fluid responsiveness, when the hypovolemia is obvious, you don't need to check for the fluid responsiveness. It comes from the next phase. What are the phases of a fluid resuscitation?
The rose
Excellent.
versus
Full form.
resuscitation, optimization,
Very good.
stabilization, and that
Excellent.
excretion order.
Any other protocol you know? Yeah, ठीक है, ठीक है. Any other protocol? DOSD protocol? पढ़ लेना. These are theoretical. I don't want to bluff on this theory here. Right. So चलो, ये concept तो हमारी हो गया. Fluid responsiveness हमने focus कर लिया. Now comes the second paragraph. So
So,
what? Say, read.
so four units of blood transfused, 4 units of random donor platelets transfused, and 2 units of FFP transfused. Endoscopy done on the bedside, and 2 columns of large varices, EVL were done, and portal hypertension gastropathy was noted.
Right. So do you think it's a massive blood transfusion?
Yes.
What
4
do you
units
mean by?
in there is a transfusion of 10 units in 24 hours, or 4 units in three hours. We can say that's a massive transfusion, or more than 50% of the patient's blood volume being transfused in
4
3
units
hour
in
3
4
hours.
units in 3 hours
4
or 4
units in
units in 1
4 units
hour.
in 1 hour, 1 hour, 1 hour.
Exactly. So you
And
could have asked me, sir, आपने कितने देर में दिया है, right?
yeah.
So whether it's a full 24 hours transfusion or it's an 1 hour, 2 hours transfusion. So no doubt, we have given a blood, we have given a platelet. As we are giving a 4 unit of RDP, we can expect dilutional thrombocytopenia, dilutional coagulopathy. So we have used 2 unit of FFP, right? So an endoscopy, you could have used 2-3 units of FFP, but it can be a cirrhotic patient, so cautious use of FFP. So endoscopy is also done, and 2 columns of large varices and the EVL is done. So now it's pretty clear we are dealing with an chronic liver disease induced or a portal hypertension induced bleed. It's very clear. Clear?
Yes.
So can you say me when I say portal hypertension, what I mean by its definition?
Portal hypertension, hepatovenous pressure gradient should be more than 5.
Excellent. When I say
If it is,
clinically significant portal hypertension,
if it is more than 10, it is clinically
what
significant.
do you mean by this HVPG?
It is a difference in the pressure gradient from the hepatic and the portal.
Exactly. So it's a difference in the hepatic vein and the portal vein. A balloon is float when the free hepatic vein pressure is taken, which indicates the hepatic vein pressures. When the balloon is wedged, it indicates wedged hepatic vein pressure or the portal pressure, right? So it can be transjugular or femoral. So the difference is normally 1 to 5. You have excellently said the portal hypertension is greater than 5 and the clinically significant portal hypertension is greater than 12. Now, in your life, how many times you have seen this HVPG being done? Trust me, if you ask me, working in a very high-end liver institute, right, in Delhi, I have seen 2 to 3 times in my 4 5 years in this hospital, right? So how many times you have seen HVPG?
I have not seen some.
Very good. That is the reality. So my question is, if I don't have an HVPG in a bedside, right? So how can you say in a by non-invasive test that the patient is having a clinically significant portal hypertension? Three.
Transient elasto
Do you have in your hospital what's that thing called?
fibroscan.
Very good. Do you
It is
have in
being
your
done.
hospital? It's done. Right. Can you just say me what's the cutoff for the cirrhosis, liver stiffness?
50%.
No, not percent. It's kilopascal. It's
Kilopascal.
uh, it's 12 to
Yeah,
15,
12,
right?
12, 15
Yeah, right.
kilopascals.
So the grade fibrosis grade 4 F4, what we say, it's 12 to 15 kilopascal, right? This is very good. Number one, fibroscan. Second, in investigation, I am giving you clue. A very common investigation which you do daily almost in your ICU.
Platelets,
Exactly. Very good. Thrombocytopenia. And
thrombocytopenia.
another one is not properly non-invasive. It's a minimally invasive. What you have done in this patient already? It's endoscopy, right?
Endoscopy.
So presence of a varus, presence of and fibroscan liver stiffness or LSM greater than 12 to 15 kilopascal and a thrombocytopenia give you a clue that you are dealing with an portal hypertension. Clinically significant, it's above 15 with thrombocytopenia or above 25 without thrombocytopenia. Read the beautiful guideline of ASLD, portal hypertension and the upper GI bleed, which we also read before our exam. It has now been updated also. Very beautiful story-like guideline. So you read that guideline, right?
Okay.
So CSPH we have discussed the non-invasive method. Now you so चलो नेक्स्ट देखते हैं मैंने क्या डाला है. तो अभी पैरामीटर्स इन्वेस्टिगेशंस आ गया, रात बीत गया, मॉर्निंग sun has already started to see in the sky, so it's a fine morning. तुम्हारी भी कंसल्टेंट भी उठ गया, उठ के तुम्हें कॉल कर लिया कि पेशेंट कैसे है उस रात में, बिकॉज यू आर द ओनली हीरो एट द नाइट टाइम, राइट? सो दिस वॉज एन investigation which has gone from the ER, right? So it's 4.2. After that, you have given 4 unit of PRVC, 4 RDP, and 2 FFP. Platelet count is 80,000. TLC is 15,000. BUN 45. Creat 1.7. SGOT 886. SGPT 645. INR is 1.9. And ammonia is 92. Right? फर्स्ट ईयर ने
Yes.
नोट डाउन कर दिया तुम्हारी चार्ट में, तुम आए अभी देखने कि ये रिपोर्ट्स में ये है. सो कैन यू गिव मी सम इंप्रेशन फ्रॉम दिस रिपोर्ट, व्हाट्स गोइंग ऑन योर माइंड?
He's having hepatitis more than 5 times SGOT SGPT elevation is there.
So do you
With
think ठीक है, बोलो बोलो, you complete your statement.
there is
In hepatitis, which one goes
uh,
high much, मतलब higher, OT or PT?
um, liver specific is ALT.
ALT, which one is this? हमने तो इसलिए नाम ऐसे दिया कि ALT AST तो हम पढ़ते ही है. So which one is this ALT?
SGOT.
SG?
SGOT.
No, SGOT is AST, right?
AST.
SGPT. याद रखना, the pyruvate get converts into alanine, right? So
Yeah.
PT is here pyruvate, alanine is ALT, राइट. ये याद रखना कि ये तो हमारी बायोकेमिस्ट्री का टीचिंग है. ट्रांसअमाइनेशन होता है पायरुवेट टू एलानिन, राइट. सो इट्स पायरुवेट गेटिंग कन्वर्टेड इनटू एलानिन. सो SGPT is ALT, right? So here AST is more than ALT. What is your impression? What could have been the cause?
AST is more than ALT. We have to think about alcoholic patients. It will be AST ratio more than 2 will be seen.
So does it fit with the definition of alcoholic hepatitis? Though the patient has already
No.
gone into decompensation, but the alcoholic hepatitis criteria is up to 400, right?
Okay.
So it can be due to alcohol. You are pretty right. One more thing which has happened with this patient.
Having anemia.
Not exactly anemia. What I want to hear from you is an hypotension, which could have caused an ischemic hepatitis. And though the numbers will be pretty high in that, but as you have well resuscitate you and your junior, so the patient hasn't gotten very high SGOT, SGPT. But remember these two famous condition. One is alcohol, you are right. And the ratio, rights ratio 2:1 greater than 2:1, and another is this ischemic hepatitis where you get an OT greater than PT along with an elevation of LDH, right? So when you see an OT greater than PT with an elevation of LDH, always think that this is due to the ischemia. As you resuscitate and stabilize the patient, this will normalize. तो चलो OT PT का बात हो गया. What about the count?
Count is elevated.
So it's an infection or something else?
I think suspect an infection.
So you have got a focus, a straight shine in the right base, right?
Yes.
Right. So it's an infection likely. After a bleed, it can also be a reactive. Am I right?
Okay.
After a bleed, the patient can also have a reactive increase in the TLC, right? What, anything more? Platelet signifying CLD, no doubt. That there's thrombocytopenia, 80,000, right? It has been given before the transfusion, so do not expect any dilutional thrombocytopenia. So it indicating towards CLD. TLC 15,000 can be reactive, can be your right-sided pneumonia. Now, creat. Do you stamp this creatinine? Baseline was fine. Baseline was 0.8. So, do you stamp this creatinine to be hepatorenal syndrome?
Because of the shock, we can some prerenal causes of AKI.
Excellent.
Has to be
Excellent.
considered.
So, you have to rule out the prerenal causes or the hypovolemia before you go to the hepatorenal syndrome. So, few words regarding hepatorenal syndrome. Why do you think the hepatorenal syndrome happens?
Renal vasoconstriction,
Why this happens?
because the sympathetic overactivation and
Why that happens?
because
Because there is see 2-3 things. One,
splanchnic vasodilation and
very good,
sympathetic
very good.
overactivation.
Splanchnic vasodilation. Why this splanchnic vasodilation happens?
The nitric oxide and all is released and
Very good. The toxin and the nitric oxide.
toxins there.
So, right. So that splanchnic vasodilatation happens. There is a pooling of blood in the splanchnic circulation. There is a decrease in the blood flow in the renal, and there is an activation of RAS, and there is an decrease in the urine output. So, can you classify HRS according to the recent 2025 guideline? What
Sir,
first? What are the criteria for defining a HRS?
Sir, we have to withhold all diuretics and
No, first criteria.
we have to rule out all other causes of
First, उसके भी पहले.
increase in creatinine more than 0.3 in
उसके भी पहले. वो तो आएंगे, बाद में आएंगे. पहले तो पेशेंट को आइडेंटिफाई करो कि इसमें HRS हो सकता है.
CLD patient.
Very good. CLD cirrhosis. Second,
cirrhosis.
presence of ascites.
Ascites. Yeah.
Right? It should be there. Right? A patient cannot go into HRS without an ascites being present. Right? Because अगर ये सब तुम्हारी सिंपैथेटिक ओवर एक्टिविटी, फ्लूइड रिटेंशन, ये सब होगा, पहले तो ascites होगा. Right?
No. No.
So presence of cirrhosis, presence of ascites, then what you are saying, increase in the creatinine of 0.3, right?
0.3.
In the 48 hours or from the 7 days. From
1.5 times
yeah,
baseline.
Yeah. And then
we should rule out the other causes of AKI, and we should resuscitate the patient with around 1 gram of per kg albumin and withhold diuretic medications for 48 hours.
So will you resuscitate all the patient with albumin? So the recent guideline, you go back and read that International Club of Ascites, we just published before our exam in 2024, and right there the criteria से ये हटा दिया, ये albumin वाला resuscitation part, exclusion of hypovolemia. Why we are concerned? Because the patients are already on diuretics, so the patient can come with a GI bleed. What is the case here? So we have to exclude the hypovolemia before stamping it as HRS, right? So going forward, this you have very well said that we have to exclude pre-renal before saying. So do not jump any AKI in a CLD as an HRS, right? So what should be the treatment of choice in the HRS?
Terlipressin.
Is it initial treatment or treatment of choice?
Treatment of liver transplant.
Exactly. The treatment of choice is liver transplant, right? So if it is asking treatment of choice, then bolna ki side it's liver transplant. Initial treatment is terlipressin or the vasoactive agents, right? So once the HRS has set in, you cannot deny of doing a transplant, and you have to start on counseling regarding the liver transplant in that patient, right? So here also the story comes like a same thing. Turley, नहीं तो नॉरेपी, नहीं तो octreotide. We are not going into because ये तो तुम्हें theoretically पढ़ना ही होगा. इसके लिए practical discussions की कोई जगह नहीं है. Let's finish off within 15-30 minutes because it's already 8. अभी X-ray आया. Ignore this download of this X-ray from Google and the absence of the ET tube and central line. Yeah, ignore karo because I have taken this X-ray from Google. So what's your impression in this X-ray?
It's a right lower zone patches.
Is it lower zone?
Mid.
Very good. Bolo?
Mid zone.
Yeah. How you say it's mid zone? because it is obscuring the heart border,
Heart.
right?
Heart body.
So the diaphragm border is intact, right? So
Okay.
it's a right middle zone pneumonia. It's not a lower
Lower
pneumonia.
zone pneumonia.
It's a
Okay.
right middle zone. So now, do you want, acha, chalo. Anything more you want to do in this patient?
Anti-encephalomytic measures.
चलो, anything very urgent you need to do within this time. Morning हो गया, एक्सरे आ गया, डिस्कशन हो गया, कुछ तो करोगे जो पेशेंट का सोर्स हो सकता है. एक तो न्यूमोनिया हमें मिले, हमने
Pneumonia.
इतना सेप्ट्रियाक्सोन के
Okay.
बारे में बात किया.
Uh,
सो वी विल डू अ,
Ball.
नॉट बाल, अभी बाल नहीं करेंगे. वो तो चलो कोई रेसिपी वाला आ गया तो कर लेंगे, लेकिन अभी नहीं करेंगे बाल अभी के लिए. लेकिन अभी के लिए तो वी विल,
Sputum.
हाँ,
Sput,
we will do a tapping, right? Ascitic tapping, right? So the patient umbilicals was everted. There was a dull
Yes.
on percussion, right?
Yes.
So we do a tapping of 6 liter. How much albumin will you give?
1 gram per liter.
Is it starting from 0 to 6 or above 5 liter?
Above 5 liters.
Exactly. So when you are doing a large volume paracentesis above 5 liter, then we will be giving per liter 8 gram, right?
5 grams. Okay.
So why you give this albumin?
So it's indicated for large volume paracentesis
Why?
because of the hemodynamic collapse.
Yes, yes. What is the term? Paracentesis induced circulatory dysfunction, right? Criteria is by measuring renin. There is a increase in the renin level, because same thing. Ascites हटा दिया, splanchnic vasodilatation जितना हो रहा था कम हो रहा था, because there was a pressure, वो हट गया. So there is large pooling of blood in the splanchnic circulation, right? And more blood comes here, less goes to the kidney. There is a RAS activation. There is more accumulation of ascites. So you will, at the bedside, you will get an hyponatremia if the patient develops paracentesis induced circulatory dysfunction. Also, you can get a breathless patients. So to stop all this, we give an albumin, right? Now तुमने टैपिंग कर दिया, टैपिंग का रिपोर्ट आ गया.
Yes.
इवनिंग तुम जा रहे थे घर शांति से, तो जो ओवर लिया उसी टाइम सिस्टर ने बोला सर टैपिंग का रिपोर्ट भी आ गया. So what's your impression from this tapping report?
Sir, there is SBP because the
Is it,
absolute neutrophil.
बोलो बोलो.
So if absolute neutrophil count of more than 250, we can take it as so here 80% of 1200, 900 something.
So is it SBP or neutrocytic ascites? I have not talked about culture till now.
Neutrocytic acid.
Right? So culture can be positive, culture can be negative. So your approach. So now my question is, if the culture comes negative here, will you treat this?
Yes.
Yes. Remember in this, in your life, that this inflammation or the neutrophil count is more important, right? So if you get a ANC greater than 250 and a culture negative, you treat. If you get a ANC less than 250 and culture positive, you repeat the culture. Because एक बैठे बैठे एक इन्फेक्शन हो गया और कोई इन्फ्लेमेशन नहीं हुआ अंदर, इट कैन नॉट हैपन, राइट? इट इज क्लासिकली रिटेन, नो कंफ्यूजन. न्यूट्रोसाइटिक एसाइटिस treat. Bacteria ascites where there is no ANC greater than 250, you repeat the culture, right? If there is
Okay.
an other source of infection, you can treat. Right. Now, any comment from this SAG?
Tag is more than 1.1.
So,
Um, more towards cirrhosis,
cirrhosis or can be cardiac also.
cardiac.
Right. So that we will differentiate from the ascitic protein. चलो, नेक्स्ट डे तुमने शांति से घर गया, नेक्स्ट डे तुम्हारी कल्चर आया एसबीपी में ये। तो अभी तक
Mm.
तुम एंटीबायोटिक दे रहे थे मोनोसेफ, रात में तुम्हारी जूनियर जो ड्यूटी पे था उसको टैजक ने किया है, लेकिन रिससिटेशन हेमोग्लोबिन हैज क्लाइम्ड अप, बट द पेशेंट बीपी इज नॉट क्लाइंबिंग अप. The patient is still is on sepsis with a low diastolic indicating towards a septic shock, right? So this is your
Yes, sir.
culture. What will you continue with Tazac or will you change to something else? What is the impression from this culture report?
I'll change to meropenem.
Why? You are right. Why? One reason is it is not coming down on Tazac. So the patient is clinically not improving, right? So
Yes.
that is absolutely, I agree. From this culture, what is your impression? I know it's becoming hectic because 2 hours is too much. So I will finish off it within 1.5 hours. So you are comfortable now with the discussion. So we are
Yes, sir.
only discussing what can be asked in the exam. Just go back and read these things, right?
Yes, sir.
So I can say you I have attended 3 cases before exam, 4, right? 2 of Yashoda and 2 of somewhere else, one in Gangaram, and so it is of immense use, immense, who are not sitting here because of fear, they are losing something and they will realize on the day of exam, right? It's hats off to you that you have come forward. It will give you an immense help during the exam time. देखना कि वो जब जाओगे ना फ्लाइट पकड़ के दूसरे स्टेट में एग्जाम देने, कान में ये सारे बात तुम्हारे गुजेगा कि ये सर ने बोला था क्लोरेक्सिडिन का भी देख के जाओ यार, ये कौन से एग्जामिनर आता है क्लोरेक्सिडिन भी पूछता है, ठीक है, बट पूछता है ये बिकॉज यू विल बी सेइंग कि आई हैव डन द टॉप मोस्ट डिग्री, गिव मी XYZ salary, right? So this should be your standard. So what is your impression from this antibiogram?
Is resistant to many levoflox.
Any
Cifotax.
specific name? It is, I'm giving you a clue. It is resistant to Aztreonam. It is resistant to ceftazidime. What class of antibiotic is this ceftazidime? It is third generation
Third
cephalosporin,
generation
right?
cephalosporin.
So third generation cephalosporin resistant, Aztreonam resistant. Anything in mind?
Metallo, betal.
No, not metallo. It's not metallo. Metallo-beta-lactamase comes in carbapenem resistance, right? So it is ESBL or extended spectrum beta-lactamase, right? So it's an ESBL. The Merino trial says giving meropenem is the drug of choice, right? In case of an ESBL organism, right? So we change it to the patient. So very important. What IDSA says, if you get this type of antibiogram where Tazac is sensitive, if the patient is improving, coming down on vasopressors and not throwing fever, then cefepime and Tazac should be continued, even if it is ESBL, right? It is clearly in IDSA 2025. But if the patient is not improving, if you have any doubt, the drug of choice is meropenem, right? Mainly it has said regarding uncomplicated cystitis, but also in other cases, if your patient is improving, कभी होता है कि हमने भेजा टैजेक्ट आए लेकिन ईगो पे ले लेते हैं हम, ESBL आए, हम इंटेंसिविस्ट है क्वालिफाइड वाला, हमें तो करना है मेरोपेनम, नो, that you should judge at the bedside. But as the patient is still hypotensive, I should have given this also, I have said it verbally. So still hypotensive on high dose of vasopressors, the choice of antibiotic we will change to meropenem. Now आ गया तुम्हारी patient is improved. Now तुमने meropenem कर दिया and patient has improved, and now you start weaning the patient. Now tell me a few lines regarding feeding of this patient. What should be your feeding plan in this patient? Patient is intubated.
Sir, we should target for a protein of around 2 gram per kg.
It's 2 gram, 1.2 to
1.5.
1.5. 1.2 to 1.5.
0.5.
So, and
So
calories?
then calorie of around 25 kilocalories per kg per day.
So,
Then
you
try to
say
achieve the caloric intake by around 5 days as the patient tolerates.
exactly. Very good. So you should be starting like this. As the patient is intubated, we will be giving an enteral feed, right? Targeting a calorie and protein. So do you think in a CLD patient, to prevent HE or the surge in ammonia, we should be targeting low protein?
So now they're saying that there is no need to target a low protein.
फ्लैट कराना एक बार इनमें से
Please mute.
पूरा फ्लैट करना ठीक है
Please mute. Please, anybody from here, please mute.
Sundar, please mute the mic.
Huh. So, any role of decreasing in the protein as a patient can land up into, because we are concerned regarding ammonia, right?
Yes, sir. Yeah.
Any role?
Sir, before I think it was said that we have to go for protein restriction, but now there is not much role of a protein restriction. We have to maintain the
Excellent.
muscle mass for
Excellent. Why?
because muscle is a sink for ammonia. Like it will
Very good. Excellent. So we have to avoid sarcopenia, right?
sarcopenia.
So very good. Excellent. So this is the recent SPEN guideline for this liver disease patient. So in which category you need to restrict protein? Any liver disease? In acute liver failure, right? In acute liver failure, if the patient is on high grade of HE, 3 or 4, then we can reduce the protein intake for some days, right? And while sarcopenia is an risk factor for the CLD, the obesity or the overweight is a risk factor in case of ALF, because more is the obesity, more is the inflammation, right? Because in ALF the game plays more is the inflammation, right? So the cerebral edema, everything what it's happened. So chalo, feeding, you have cleared your so I have jotted 14 15 in my papers. So feeding wala part you have cleared. Now coming to the weaning mode, what mode are you seeing in the screen?
Pressure support.
Very good. What is the TLC of this pressure support mode?
Flow trigger.
It's not flow trigger. See, pressure support is a spontaneous breath, right? So you see a notch at the start of this pressure. So this is
pressure
a
trigger.
patient trigger.
Yeah, pressure trigger.
Patient is taking a breath and the ventilator is supporting the breath. So it is basically a support, right? So it's a patient triggered. It's a flow cycle.
Flow cycle.
Right? So it's a precious triggered flow cycle. And what is limit? देखो एक स्क्वायर हो रहा है ना, कौन लिमिट हो रहा
Yeah,
है, दिस इज प्रेशर. सो
for sure.
सो वन थिंग वेरी क्लियर,
Yeah.
एबीजी, थ्रोम्बोप्रोफाइलैक्सिस, वेंटिलेटर, एंटीबायोटिक्स, ये सारे चीज को ना अपने अंदर
Yeah.
घुसा लो. ठीक है, जो थियोरी पढ़ रहे हो पढ़ो, इसके साथ साथ एंटीबायोटिक. वी कैन गेट इन टच आफ्टर दिस सेशन ऑल्सो, यू कैन टेक माई फोन नंबर्स. So anything, any help you need as a senior, I am ready to help you. So the thing is कि तुम ये एंटीबायोटिक, थ्रोम्बोप्रोफाइलैक्सिस, वेंटिलेटर, इन्फेक्शियस कंट्रोल. बिकॉज क्या होता है, जब एग्जाम में ना यू स्टार्टेड फम्बलिंग, तो एग्जामिनर बोलता
Mm.
है ठीक है बेटा, तुम ये एबीजी बताओ. सो तुम
Okay.
rock there, right? Sometime a patient comes alphos poisoning. तुम पता नहीं कितना अल्फोस देखे हो, मैंने तो जिंदगी में एक की दो ही देखा है. ठीक है, सो तो
Yeah.
पता ही नहीं था वो तुमने तो अपने अच्छे दोस्त से पता कर लिया केस अगले दिन, लेकिन मुश्किल से उसी मॉर्निंग वो अल्फोस पॉइजनिंग एडमिट हुआ और एक्सटर्नल आके बोला अच्छा अच्छा अल्फोस पॉइजनिंग है, यही डाल दो. तो तुम्हें
Yeah.
अल्फोस पॉइजनिंग पता हो कि ना हो, तुम्हें एबीजी, वेंटिलेटर्स, हेमोडायनामिक्स, एकमोस, ये सारे चीज पता होना चाहिए. Right, so
Okay.
the thing key, the basic requirement of an ICU. So why I am saying this TLC, trigger limit control, आज जाके एक पेपर में VCV, PCB, प्रेशर सपोर्ट एंड PRVC, ये चारों को लिख के दीवार पे लगा के रखो. You should not do any mistake, right?
Yeah.
And another thing is ABG, nutrition, fluids, thromboprophylaxis, vasopressors, सेप्टिक शॉक. कुछ नहीं पता होता है ना, लास्ट में पूछता है बेटा बोलो एआरडीएस का डेफिनेशन बोलो. सो ये सारे चीज तो तुम्हें, बिकॉज सी एग्जाम में ना ये सर्किट उड़ जाते हैं, जो भी आता है स्पाइनल कॉर्ड से. ठीक है,
Yeah.
इफ कोई नहीं, किसी ने बोला मैंने बहुत सोच समझ के एग्जाम में आंसर दिया, तो झूठ बोला. ठीक है, हो ही नहीं सकता है सोच समझने का, वो तो फंक्शन, हायर फंक्शन तो स्टॉप. ठीक है, सो जो भी होता है स्पाइनल कॉर्ड लेवल से. सो ये इसको ना स्पाइनल कॉर्ड लेवल तक लेके आओ, ये टाइम
Yeah.
लगता है. यू हैव एनफ ऑफ टाइम इन योर हैंड. योर एग्जाम विल नॉट बी, यू आर इन दिस कैटेगरी ना जिसमें जून में एग्जाम होने वाला है ना, कि नहीं
Yeah.
होगा. हाँ, वो शायद नहीं
September,
होगा.
October.
हाँ, सो इट विल गेट डिलेड. सो ट्राई टू कोप अप मोर विद दिस टॉपिक्स, राइट? चलो
Okay.
आगे बढ़ते. पेशेंट था अच्छा, एक्सट्रूवेट हो गया, शांति आई कि उस रात तो मैं ही ड्यूटी में था इसलिए पेशेंट बच गया, राइट? सो मॉर्निंग राउंड पेशेंट वाज एक्सट्रूवेटेड, नॉर-एपी में था. व्हाट टू मॉनिटर इन दिस पेशेंट? एक्सट्रूवेट हो गया, नॉर-एपी में है, 2 ml/h, एक्सरे भी इंप्रूव कर गया. सो व्हाट नाउ यू नीड टू मॉनिटर इन दिस पेशेंट?
Sir,
जो तुम मॉनिटर करते हो नॉर्मल बोलो कुछ, ये रॉकेट साइंस नहीं है. एक हाइपोक्सिया ना हो,
hypoxia.
हाइपोटेंशन ना हो, राइट?
Yeah.
पेशेंट
Yes.
एस्पिरेट ना करे अगर हम
Yes.
फीड स्टार्ट कर रहे हैं. एंड
Yeah.
पेशेंट, मोस्ट इंपॉर्टेंट, पेशेंट एची में ना जाए. एनी चेंज ऑफ सेंसोरियम. So now we are entering the topic hepatic encephalopathy. So can you say me what are the 4 pillars of judging an hepatic encephalopathy? One
Uh,
is type.
right.
What are the type? A, B, C. In CLD, what type you expect?
Uh,
C,
Option no. C.
right? You remember C for cirrhosis, A for ALF, right? Type A in ALF, C in cirrhosis, right? And B is in a patient with a portosystemic shunt, right? So it can be
Yeah.
congenital or can be associated with some pathologies, right? Which is not related to ALF and CLD. So ये ABC तुम्हें याद रखना है. वेस्टर्न हेवन क्लासिफिकेशन तुम्हें याद रखना है. ट्रीटमेंट में आता है lactulose and rifaximin.
Lactulose.
Can you say
Vaccine.
the mechanism of lactulose?
So lactulose basically it, acidifies the gut and it
Excellent.
expulsion of the stool, increasing the. We have to target a stool output of around 2 to 3 per day or a Bristol chart of 4 to 5.
Very good.
And
Very good. That exactly what is need to be here from you is the Bristol classification, right? ऐसे तो चलो कोई भी थोड़ा stool pass कर दिया 2 से 3 बार. So excellent what you are saying. A recent guideline has come 2026 का ACG hepatic encephalopathy guideline. देखना उनसे वहां पे clearly written this 4 to 5 Bristol classification. Now HE, so when a patient goes into an HE, do you think of anything? What are the precipitating factors you think of?
Constipation.
Very good. Something more? Infection can also precipitate.
Infection. Urea is producing bacteria.
Not ureas, any infection, a pneumonia.
Any infection.
See, what will happen? It will increase the portal hypertension. It will increase the portosystemic shunt. It will increase the delivery of ammonia in the brain. So, what exactly this ammonia, what type of cerebral edema this ammonia cause?
The astrocyte.
What type? Cytotoxic edema, right?
Cytotoxic edema.
So there are many causes: vasogenic, cytotoxic, osmotic, right? Interstitial. So this is cytotoxic edema. Chalo, baat hai ki, so you have to look for a precipitating factor. It can be an infection, it can be a dyselectrolytemia, it can be an hypovolemia, right? And it can be your constipation. So when a patient comes to you with an HE, you have to, ye yaad rakhna, not for only HE. Also, if a patient comes with a DKA, you have to look for the precipitating factors, right? What I mean by precipitating factors means any source of infection. जब तक तुम वो ढूंढ के नहीं निकल रहे हो, you should not sit in your chair.
Okay.
A diabetic patient does not equal to DKA. A CLD patient does not equal to DCLD, right? If a patient has decompensated, you have to find out some factors, be it be a dyselectrolytemia or an hypovolemia due to the overuse of diuretics or an infection in any source. So that is the reason I haven't asked you, you have to send a culture. Now on the Day 6, the patient requirement increases, vasopressors increases, patient started throwing high fever, right? What will be your plan of action now? Patient is on meropen now.
He's having a new onset hospital-acquired infection.
So what do you expect? Having increasing oxygenation level.
The VAP.
So do you think a patient who has been extubated can have a VAP? Yes. The timeline is 48 hours after extubation, right?
48 hours.
So the patient has not gone 48 hours after the extubation. So the patient is having likely a VAP. So we have to escalate the antibiotics because meropenem already on 4 day is now having an increased vasopressors and having an increased oxygen requirement. So we will be sending cultures. Slowly, the vasopressor kept on increasing, abdomen got distended. The Purani wala kahani, patient is starting having accumulation of ascites again, right? Urine output decrease and the patient is having metabolic acidosis. So in a patient with a decreased urine output, now you are suspecting the patient to go into an hepatorenal syndrome or an septic associated AKI, any one of this. So you will be excluding the other factors and we can think of hepatorenal syndrome and the patient's urine output now started decreasing, right? So when a patient urine output is decreasing and ABG now comes to us, we have already done a session with discussion with an ABG. I'm not asking you this ABG again, right? And now the patient got intubated and the chest x-ray shows, sorry. and the chest X-ray shows left lower zone consolidation, right? And now the parameters comes in the subsequent days like this. Now, what's your impression where the patient is going now? So there is an increase in creatinine.
Sepsis.
It's a
Sepsis was
sepsis. Obviously sepsis, no doubt about that. But where the patient, so the patient is got reintubated, so lung has failed. The patient on high vasopressors, right? The circulation has failed, right? And patient has high creatinine, the kidney has failed, patient has high INR, the patient has become coagulopathic. So the patient is now entering from decompensated CLD to
ACL, ACLF.
very good. It's acute on chronic liver failure.
Chronic liver
Today
failure.
we will not be discussing acute on chronic liver failure because that can be a total separate class or a session of discussion. But the concept what I tried to build you up, that how a patient from DCLD goes into an ACLF, and now as you have an ये ना picture ही problem कर रहे हैं. एक second please. Now, as you have an INR of 2.6, you plan to do and TIG. So, any comment on this TIG?
So the gate time alpha angle and all is reduced.
Very good.
Alpha
So,
angle
कौन सा product दोगे?
is high. We have to supplement with coagulation. Hypocoagulable state.
What are the products are you going to give in this patient?
There FFP and fibrinogen.
Excellent. Fibrinogen कैसे दोगे? Raw fibrinogen or some?
Cryoprecipitate cryo.
Excellent. What will be the dose of cryoprecipitate?
10.
The cryo. So it is said 0.2 into body weight, right? So 0.1 कोई कहते हैं, कोई 0.2 कहते हैं. So we do 0.2. So if a 60 kg body weight, it's come around 12 bags. So it comes in a set of 5, right? So हम 5 देंगे कि 10 देंगे, right? So cryoprecipitate, you can also give raw fibrinogen, 1 gram or 2 gram. That is also available. So you are right. You have to give FFP. So now the question comes. Now the recent trial says. So we are just last but one slide. So you can give FFP or you can give PCC also, right? Because FFP में तुम वॉल्यूम दोगे वो फिर पोर्टल हाइपरटेंशन को एग्रावेट करेगा. So right. So in liver transplant there is an extensive use of PCC. So read the use of PCCs in these circumstances, right? Otherwise you are right. Well, good. We give FFP in this scenario. PCC is still a luxury. So FFP and cryoprecipitate. Right. Now the patient bronch has been done. And this is the organism what you are waiting for, and the patient is on meropenem and you have added a polymyxin B. What will be your thought process regarding the antibiotic?
Ceftazidime अभी
बोलो बोलो सही बोल रहे हो बोलो ना.
Ceftazidime avibactam aztreonam combination.
Why? मैंने एनिमेशन ऐड करने भूल गया था कि यो एनडीएम दिखा दिया तुम्हें. एनडीएम ऑक्सा 48 साइनाइडजीन. सो व्हाई?
Because of this.
Why not? See, one thing मेरे को बोलो, कोलेस्टिन तो है इंटरमीडिएट. सो कोलेस्टिन इंटरमीडिएट मतलब हमारी जमाना में सेंसिटिव, राइट? Can you say me why this colistin is given intermediate in all antibiogram? Classical examiner question. I can assure you that I will say you the right reason. So I want to hear from you. Because मैंने ना जब DRNB था, मैंने I asked this question 30% and they are divided into 4-5 groups. कि कोई ये बोलता, कि वही बोलता, कोई वो बोलता. मतलब but I have tried to find out from the exact place where this I was termed. So तुम बोलो तो what you know, ये colistin I क्यों? Why this colistin is I?
Not sure, sir.
See, the colistin is I. The reason being in 2020, before 2020, UCAST and CLSI. These are the two groups which determines this MIC, right? In 2020, CLSI issued an brochure or an article where they said that this colistin or the polymyxin rather are not able to achieve concentration in the alveoli, right? So as it cannot achieve the concentration in the alveoli, so it cannot be given as a single agent. So we remove the tag of exact this line is written. Go back CLSI 2020. They came out with a brochure. That is why they change it from sensitive to intermediate, because it cannot achieve significant level in the alveolar epithelium, and that is why it cannot be used alone. Another version which circulate in the market is the type of test, right? So colistin ideally should be tested by broth dilution test, right? But we do through Vitek, right? What we test in our laboratory is Vitek. So Vitek sometimes underestimates the MIC, which seems to be sensitive in Vitek can comes resistant in broth dilution, right? So that is why for these two reasons the colistin is said I, right? So we have colistin I, so means it's sensitive, so we will not be continuing with polymyxin. What you said, ceftazidime avibactam and aztreonam is exactly the right answer according to the IDSA guideline when you have done with the synergy test. But why not polymyxin B? Because polymyxin B cannot achieve a good level of concentration in the alveolar epithelium, and we are dealing with an pneumonia. In the ball culture, the Klebsiella has come. Nebulization colistin is totally out now. We have stopped using, right? Because it doesn't create anything except nuisance, which is bronchoconstriction, right? And we have seen many patients going into volume control mode from pressure support by using this colistin, because sister do not nebulize with duolin before and after that. So the right choice is ceftazidime avibactam and aztreonam, and now the pharma companies have come with aztreonam avibactam. So I think we will be shifting to aztreonam. I am not asking you now here why this ceftazidime avibactam and aztreonam, right? So we are in a hurry of finishing it within 5 minutes. So the last slide of today, the patient land up in an anuric phase and the nephrologist advised dialysis. Now, 3-4 questions sequentially. As an intensivist, what are your indication of dialyzing an AKI patient? Last slide.
Sir, electrolyte systems like hyperkalemia, refractory acidosis, then
Acidosis
uremic
means
encephalopathy.
7.3.
Less than 7.15. 15.
Bolo.
And then uremic encephalopathy,
Very good.
pericarditis.
Very good. There is a pneumonic AEIOU. right? So go back and read,
Um,
right? Acidosis, electrolyte imbalance, intoxication, right?
Intoxication.
So uremic,
Fluid
so
or
there is an AEIOU, there is a mnemonic. So last two questions. What is shown in the screen?
this is a CVVH
What type
DF
of dialysis is it?
continuous CRRT.
Very good. What is the mode?
CVVH DF
Full form?
continuous veno-venous hemodiafiltration.
Very good. So what is the last question? What is the dose of this CVV-HDF?
So for septic patient, I think 35
What is the dose shown in the screen?
effluent.
Just in the
Uh,
screen. तुमने जब when you will arrive at the bedside, the patient will be on CRRT, right? So your exam
yes, sir.
starts from here. Actually, all what happened for the 2 hours is an imaginary situation, but wait, so you cannot escape CVV-HDF. So the dose here is 2450 divided by 80. It's coming around 30.6, right? So dose of CVV-HDF, dose of CRRT, dose of intermittent hemodialysis, KTYV, you should be thorough in and out, right? So
Okay.
indication, early versus late, all the trials, right? Starting
Yes.
from start AKI,
Karthik,
LN, AKKI2, everything, you should be thorough, early and late. And lastly, the dose, for the dose, more dose is required or not, the ATN trial, renal trial, right? ये तो देखो हमारी DRNB का ब्रेड एंड बटर्स है ये सब ट्रायल्स, सो हम सब पढ़ के ही जाते हैं ऑलमोस्ट. So you should be thorough regarding these trials. Okay. So
okay.
hope I have not bothered you much. Definitely some yes, right? So the thing is, so let's end up here. So you have got an idea what actually how you need to get a prepared, right? And not regarding DCLD.
Yes, sir.
So last line what I will say, try not to know the case before the day of exam, right? It's a blunder. Those who have
Okay.
tried, they have got blunder in the exam. बिकॉज वो जो बायसनेस आ जाता है ना, एसीएस का केस है, ओपी का केस है, बस एग्जाम की पहले दिन वो ही पढ़ के जाते हैं. और ये देखो तुम अभी डीसीएलटी 50% डिस्कस किया हमने और बाकी टाइम हम इधर उधर घूमा. एंड दिस इज द रियल सिनारियो, राइट? मेरा शॉर्ट केस बर्न था. एग्जामिनर 30 मिनट बाद बोला कि अरे तुम्हारा तो बान था, तुमने तो बान पे कुछ बोला ही नहीं. हाँ, तो मैंने बोला, फिर बोला कि नहीं नहीं चलो तुम्हारा तो हो गया, 30 मिनट्स जाओ. होल 30 मिनट्स वी स्पेंड इन वेंटिलेटर, एबीजी एंड फ्लूइड्स, राइट? सो उसके बाद
Yes.
मैंने तो मतलब पता नहीं उस दिन मेरा किस्मत भी अच्छा था, बिकॉज वो अगर बांध पे घुसते, वी डो नॉट हैव बार्न्स आईसीयू, तो हम तो फंस जाते, मैं तो फंस जाते उस दिन. ठीक है, आई नो बार्न्स बट नॉट एट लेवल how I answered ABG fluids and ventilators, right? So keep in mind, topic जो भी दे, it's good that they are doing an initiative. This is a very good. So you should all utilize this initiative. I will request every juniors. I have requested my juniors, but the main problem is, sir, डर लगता है. The main thing, you have overcome that डर, right? And you are facing this, right? And I am definitely sure that you will be gaining from this. This is beyond any doubt that you will be gaining from today's 1.5 hour. अगर ये सेशन ना होता, तुम तो 45 minutes we both would have spent in mobile phone, right? So in 1.5 hours we have spent for academics, and that's enough for
Yes.
the day. Thank you again. So hope we will meet again.
No. Thank you, sir. Thank you.
Sir, there is one question in the chat box, if you like to just take up that, from Dr. Shelly Rana. Sir, when in previous culture, when he answered to switch to meropenem, what did you say about sevoflurane tazobactam? What are the guidelines regarding VSBL? Please explain.
Yeah. So what I said, the guideline, what IDSA 2025 has said, that if you are getting an ESBL, which is which is denoted by a third generation cephalosporin resistant, right? So if you get a third generation cephalosporin resistant in a gram negative bacteria, it's an Enterobacteriaceae. Specifically, it indicates towards ESBL. Now the choice of antibiotic in ESBL is meropenem, that is beyond any doubt. But what the IDSA 2025 is saying, that if the patient is already on piperacillin tazobactam and or cefepime, right? Piperacillin tazobactam or a fourth generation cefepime, and if the patient is improving, not throwing fever for the last 48 hours, not mentioned this 48 hours, not throwing fever, hemodynamically stable, and the patient is improving, then we don't need to unnecessarily change the antibiotic to meropenem. Only in case of these two, piperacillin tazobactam and cefepime, if the patient is improving, especially if it is a case of uncomplicated cystitis where there is no catheter, patient is in the ward. So in that case, if the patient is improving, we can continue with piperacillin tazobactam and cefepime, because ESBL is third generation resistant. It's not necessarily fourth generation resistant, or is not necessarily fourth generation resistant or piperacillin tazobactam resistant. But we cannot take chance, so we go to meropenem straight away. But if the patient is improving, we can stick to piperacillin tazobactam or cefepime, especially if it is a case of asymptomatic, is uncomplicated UTI. Right. Coming to the asymptomatic bacteria ascites, the answer is not to treat, repeat the culture. Right. So the concept is very clear. The concept is, it's the inflammation which is more important than your culture. If you are getting a culture positive, when you are saying bacteria ascites means the culture is positive, the inflammation is absent. It cannot happen an infection occurring without any inflammation until and unless it's an HIV patient or it's an tuberculosis where you get a low ANC count, right? So it's very rare that you get a culture positive without an inflammation. So the main thing is the inflammation. So when you get an asymptomatic bacteria ascites, the guidelines clearly says repeat the culture after 48 to 72 hours. So do a tap, repeat the culture. If the culture comes again positive, then treat, right? Otherwise, do not treat. And that also, if the culture comes positive, you have to clinically correlate, right? So the catch of the line which I tried to say is, it's the inflammation is more important than the culture positivity. I hope I have answered almost all the questions.
Sir, one more asymptomatic bacteria.
I have explained that. I have explained.
There's a thank you note from the student also, from the participant. So thank you, sir. I think it's been a real marathon session once again.
Thank you.
I think we started at 7 and we are almost 9, 2 hours of session. And
Exactly.
I really express our heartfelt gratitude for your time and energy that you have spent. And certainly, without any doubt, I think Kurian Babu must have really held so much amount of stamina to go through your
yes.
questions that you have fired for
important.
2 hours. And so nicely, he has also, I think, did his best of his abilities. So thank you very much for all your sparing your time, sir. So how would you rate the answers, sir?
So, no, beyond doubt, clear pass. But the thing, when you are going for an, so we have a grading, clear pass, which is more important. So passing is no doubt for him, but the more important is go into the concepts, right? More into the concepts, and this what I have said you. Key ventilators, thromboprophylaxis, more on those, act more fast hug bid, right? Act more on that, and I am pretty sure you will get around 70% marks in the practical, right? You are well prepared in your theory, because when we are discussing regarding CLD, everything, you are well prepared, because we in an institute have 4 to 5 DRNB seats. So and we have a daily interaction with them. So I know the level of DRNB, so and DM whatsoever maybe. So you are beyond above the level of passing. So regarding today's performance, but the thing, you have to work more on the common things, right? Ventilators, thromboprophylaxis, nutrition, ABGs, right? So you work more on this, you become more confident. जो भी केस आए तुम फोड़ दोगे, ठीक है? अगर तुम्हारी, क्योंकि देखो अल्टीमेटली तो वहां ही जाएगा। सिर्फ तुम रॉकेट साइंस कोई भी केस ले लो, पॉइजनिंग ले लो, प्रेगनेंसी ले लो, आएगा वो यूरिन पे, लीवर पे, एंटीबायोटिक पे। You should be
Yes.
very strong in the antibiotic, right? You cannot ignore being an intensivist. You should give a head and head neck competition to an ID specialist. Chalo, they will win because that their specialty, but you have to be very thorough regarding the IDSA guideline, ICMR guideline, right? So ये तो तुम्हें होना ही पड़ेगा, right? Generation of cephalosporins, कार्बापेनाम्स, एंटीस्यूडोमोनाल्स, स्यूडोमोनाल्स, हाँ, ये तुम्हारी फिंगर टिप में रहेगा, ठीक है? कोई भी बात इस पे आए एंड तुम्हें लाना पड़ेगा, क्वेश्चन तुम्हारी तरफ लाना पड़ेगा। वो जो मैंने बांड की कहानी बताया एबीजी वाला में, उसमें तो मेरा यही था कि सर द पेशेंट गॉट इंटूबेटेड बिकॉज ऑफ मेटाबॉलिक एसिडोसिस। हाँ, मेटाबॉलिक एसिडोसिस में तुमने इंटूबेट कर दिया, दिखाओ एबीजी दिखाओ। हाँ, वो सर भी ईगो पे ले लिया, वेरी सीनियर कंसल्टेंट ऑफ दिल्ली एनसीआर, ठीक है? तो सर भी ईगो पे ले लिया, चलो उसमें ही बात स्टार्ट हो गया। पेशेंट रहा बाहर में इस साइड, एबीजी में ही बात चल गया, ठीक है? So I intentionally tried to do this and I was successful. Every time you will not be successful, right? So you should be very thorough regarding this. Okay. No doubt that you have
Yes, sir.
prepared very well.
Thank you,
So
sir.
thank you, sir. Thank you. I think that's a big salutation to Korean for all your hard work, sir. And you're just at the beginning of your third year. You have a long way to go. So thank you very, very much, Prithvi, sir, once again for your time. And
Thank
we
you.
really look forward to have you on our board once again in
Thank
the
you.
future.
Sure,
I think
sure,
a lot
sure.
of appreciation from the students. We're getting good comments from them. We have a lot of people join from YouTube also. So thank you very much for your time, sir, once again,
Thank
and
you.
have a great weekend. Thank you,
Thank you.
Korean. Thank you very
Thank
much.
you.
Thank
Thank
you
you.
all the
Thank you.
participants.
Thanks for the opportunity.
Thank you.
Thank you, sir. Thank you very much.